And I think it's already recording. It's automatically recording, right?
Yeah.
Haven't been eating the whole time?
They can't see it so far away.
Oh,
The
good.
candy is courtesy of Meredith. Should we just get started?
Yeah, I
you
think so, yeah.
All right, and since it's recorded, and I know people will be watching in the future, but thank you all for the opportunity, and to Meredith, of course, for setting this up. It's great for collaboration for nurses, APPs. It's a good refresher for everybody taking care of this patient population. I know there's so many new people, so some of this might be basic, but I think a good review. And obviously heart failure is a pretty broad diagnosis, so kind of hard to cut down to 15 to 30 minutes. So just kind of again, a review, and you know, if we're meeting monthly, we can, you know, take the next steps on another lecture. So just a couple objectives. I just want to review the incidence and prevalence of heart failure, some definitions, reviewing some of the terminology you guys might be seeing, just a brief review of left versus right-sided heart failure, review some of the pathophys and actually what happens for decompensated heart failure, causes that push the patients over, requiring them to come in decompensated heart failure, some exam findings, laboratory findings, management, and kind of like when to call the provider. And of course, feel free to chime in if you guys have any questions. And just to give credit to Elenia, some of these slides I did steal from her, but this is a good just review of the incidence and prevalence of heart failure. I mean, right now about 2% of the population suffers from heart failure, but that's expected to continue to rise over the next few years, with greater than 8 million people over the age of 18 expected to have heart failure by the year 2030. There's over 500,000 cases newly diagnosed every year, and like the biggest issue is that there's high readmission rates, there's high mortality even with advances in medications and other like surgical therapies. Overall, there's still the high incidence, prevalence, and a poor prognosis.
Lauren sounds so official.
I know.
Oh my gosh, dude, stop listening.
Where's she here to talk?
So just some definitions. Obviously, heart failure is a complex clinical syndrome, which is a result of a structural or functional impairment of the ventricular filling and ejection of the blood. So it can be a result of any type of dysfunction of the pericardium, myocardium, endocardium, heart valves, great vessels, so any structural problems, but the biggest thing is just it's from ventricular myocardial dysfunction. The manifestations are related to dyspnea and fatigue, which obviously limits exercise tolerance, and then fluid retention, which we see manifested by pulmonary or splenic congestion and peripheral edema. So patients with heart failure typically have like a structural or cardiac abnormality, and then when they're coming in, they have some other manifestation of heart failure. So they may have an elevated NT-proBNP level or other objective finding of congestion. So like peripheral edema, pulmonary edema, or any of the symptoms that we typically see. So just some definitions, and this is sort of new over the last few years. HFrEF obviously are the patients with the ejection fractions less than 40%. That's kind of our most common patients that we see here. We do have some that fall in this mid-range ejection fraction, 41 to 49%. HFpEF is becoming way more prevalent in the population as well, due to like the underlying comorbidities of like hypertension, diabetes, obesity. And, you know, there have been some advances in specific therapies for HFpEF before everything was really just targeted to HFrEF. So we'll probably be seeing more and more of the HFpEF patients as well. And then importantly to mention too, we see patients that had heart failure and now have an improved ejection fraction. And it's important for those patients, like they've been through something, they probably still have some type of underlying dysfunction of their myocytes. So they typically will stay on guideline-directed medical therapy long-term, even after improvement in their heart function. So again, just like reviewing some of the terminology or documentation that you might see, American Heart Association and American College of Cardiology has the various stages of heart failure. Stage A, patients are typically just at risk. They have the underlying comorbidities like the diabetes, obesity. They may have genetic predispositions to developing heart failure. Stage B, the patient does usually have some type of structural heart defect, whether it be valvular or just ventricular dysfunction. They may have elevated filling pressures and other risk factors. But the patients we typically see here are the stage C and stage D patients, the ones that are symptomatic, frequent hospitalizations. And then stage D, of course, is advanced heart failure, where we're thinking about advanced therapies such as transplant, VAD, or inotropes, whether they be like palliative or just a bridge to something else. In light of March Madness, I thought, well, Ben Gitter actually suggested I use this as opposed to a more formal schematic for the NYHA functional classes. So class 1, you have no limitations. Class 2, you kind of have slight limitations. You're able to carry out your normal activities. You may be limited, but you're able to function pretty well. And then the ones we typically see here, of course, are the class 3s and class 4s. The ones with marked limitations beyond like their ordinary activities, and then the patients with symptoms at rest. Patients, when they get admitted, they're typically, again, like class 3 or 4. Our goal, of course, is to optimize them and discharge them at a higher functional, or I guess technically lower functional class at about a class 2 is our goal to get them out of here. And just an important thing, more so for providers, but to be an accredited heart failure center, we do have to document the ACC-AHA stages and then the functional classes, both on admission and at discharge. So it is something that we do follow closely. So just, again, there's lots of new people, so I just wanted to kind of go back to like a simple anatomy review of like right versus left-sided heart failure. Most of our patients will have biventricular failure, but sometimes we do see patients with independent ventricular failure. So those with a left-sided heart failure, I don't know, does anyone want to chime in besides just reading up there, like what kind of things you might see with left-sided heart failure?
It's more like the peripheral edema, and more right side.
Yeah, so actually it's the opposite, like you're saying. So left-sided heart failure, because you typically will have the elevated wedge pressure with fluid backing up into the lungs. If it's solely left-sided heart failure, you do more so see like the pulmonary manifestations. So then the right side, alternatively, you'd see more of the peripheral symptoms. So the gut edema, ascites, hepatomegaly, peripheral edema. The way I remembered it from like nursing school is like left lung, right rest of body. So, by hemodynamics, and I know, not everyone is the 8-center nurses. We do have some that, don't deal with the swans, but what you would see with the elevated or the left-sided heart failure, again, would be the elevated wedge pressure. Right-sided would be more so the elevated right atrial pressure or the CVP. And then I also just wanted to kind of point out that, oftentimes we see valvular abnormalities for our patients, and it can either be cause or effect of the heart failure. So I just wanted to kind of reiterate which valves are on which side. For a long time it took me, I would have to refresh my memory. So on the left side, we have the mitral and aortic valves, and then on the right side, we have tricuspid and pulmonic valves. Any questions so far? So to kind of go into some just physiology, and I know we reviewed some definitions at the beginning, but just very simply put, heart failure is just a condition where the heart's muscle is unable to pump enough body or blood to the body to meet the needs of blood and oxygen flow. And then also kind of going back to nursing school, but cardiac output is calculated by your heart rate versus your stroke volume, with stroke volume being comprised of preload, afterload, and contractility. So when we see our patients coming in decompensated, it's usually an interplay between preload, afterload, and contractility, which we'll kind of get into. And the definitions there. So preload is the fluid returning to the heart. The afterload is the pressure the heart has to pump against, and contractility is really the heart's ability to pump blood, or the inotropic effect of the heart. I thought this was like a very simply put schematic of the physiology for heart failure. So patients with heart failure have the myocardial dysfunction. They obviously have heart failure. They have decreased stroke volume and cardiac output. And that kind of like stimulates this cascade with hormonal responses. So you have the activation of the sympathetic system and the renin-angiotensin-aldosterone system, leading to vasoconstriction and sodium and fluid retention. So that's why our patients oftentimes come in like clamped down, elevated SVRs, and volume overloaded. And it is kind of this like vicious cycle. So when they're vasoconstricted and volume overloaded, then it like further increases the stress on the heart, kind of like further exacerbating heart failure. So that's why we need to like intervene upon like the RAS system and like diuresis to decongest. So again, just a little bit more on congestion. And like I said at the beginning, but one of the most common signs and symptoms of heart failure is directly related to volume and congestion. And the mechanisms for fluid retention are sodium retention, either due to renal dysfunction, and then oftentimes what we see with our patients, dietary and medication noncompliance. And then, so the neurohormonal activation can kind of like redistribute fluid and just again like the vicious cycle. So it's just important to act upon that. Manifestations which we will all see with increased congestion, the elevated neck veins, peripheral or pulmonary edema, abdominal bloating, and abdominal symptoms. And then laboratory values we may see would be elevated creatinine, bilirubin, and NT-proBNP. For the systemic vascular resistance or the afterload, as far as how that plays into heart failure. So the dynamic alterations in vascular tone really are important in the pathogenesis of decompensated heart failure. I mean, we see it all the time. If we have elevated SVRs and we can get them down, like we see pretty, quick improvements in the cardiac index and cardiac output. So it's important to act on that. And again, there's a lot of words here. I don't feel like I need to necessarily just read to you, but like the biggest thing is just knowing everything kind of interplays together. If you have, vasoconstriction, it increases like fluid retention, it can worsen the kidney function, all of it, contributes to the decompensated heart failure patient. And, I kind of have to refresh my memory too on like the RAS system. So I kind of just put a couple little notes about that and how it plays into heart failure, but the stimulation of the RAS system leads to increased concentrations of renin, angiotensin 2, and aldosterone, with angiotensin 2 being a potent vasoconstrictor, leading to aldosterone release and then sodium and water retention. And then angiotensin 2 is also can contribute to myocyte dysfunction and endothelial dysfunction for the heart. Contractility, of course, inotropy, or how well the heart really can squeeze, is dependent on the myocardial contractility, and certain circumstances can like independently affect that in patients with decompensated heart failure. So ischemia, myocarditis, valvular disease, any type of pericardial disease, rhythm problems, toxic cardiomyopathies, and other metabolic derangements. And I think most of us know this, but like the very specific definition of cardiogenic shock is when your blood pressure is less than 90 and your cardiac index is less than 2.2. And I think like we're a little jaded here because we see such sick patients. We are happy with an index sometimes of like 1.9 or 2, but technically by definition, that's still cardiogenic shock. And then the manifestations of that, I mean, we see this all the time, but all markers of reduced perfusion. So you could have an elevated serum lactate level, decreased urine output, cool distal extremities, altered mental status, elevated creatinine, and liver enzymes. So are you guys familiar with this like hemodynamic profile assessment? Have you guys seen this? Sure, right? Okay. So simply put, it's if the patient is wet or dry, and if they're perfused or not, and their definitions are for congestion would be a wedge greater than like 15 to 18, and then perfusion is with a cardiac index of less than 2.2. So out of these profiles, like which one is most concerning?
Oh, no, what?
Yeah, very good. So yeah, that it really needs, we'll get into a little bit on the management of that in a sec, but yeah, the warm and dry, of course, is like a nice compensated patient, somebody we probably wouldn't be seeing here unless they're here for something not heart failure related. Warm and wet, obviously you diurese. Cold and dry, you know, you can give a little fluid back, and then the cold and wet is the one where, you know, the management is a little bit, not tricky, but they don't respond as quickly. So I just thought it would be important to sort of review some of the causes of decompensated heart failure. So like what exactly is bringing the patient in. I think this is good for, you know, so you know why we screen for certain things, check certain tests and blood tests and everything. And then also to provide education for the patients, like through their hospitalization and on discharge. So like, as we all know, one of the biggest things we see is medication and dietary non-compliance. I mean, we can talk on end to the patients about this, but you know, it's tough. I don't blame them. I don't want a salt restricted and fluid restricted diet, but that's one of the biggest things. So other things like active ischemia, arrhythmias, valvular disease, any type of infection, whether it be directly related to the heart or a systemic infection, can cause decompensated heart failure. The untreated thyroid conditions, we're always screening for TSH on admission. Alcohol and drug use, I mean, even modest alcohol use can cause patients to have decompensated heart failure. So that's another education point, you know, that they really have to abstain from alcohol after they get out of here. Genetic predisposition, I mean, we're seeing a lot of non-ischemic cardiomyopathies, and as we get more and more information from like Dr. Owen's hereditary cardiomyopathy clinic, we're finding that there really is a genetic link to a lot of the non-ischemic cardiomyopathies, including like a peripartum cardiomyopathy may have a genetic link as well. Patients that present with pulmonary embolism may have like acute RV failure. Medications like NSAID use, obviously that's a big point. If a patient's not aware that they shouldn't be using NSAIDs, can cause decompensated heart failure. Uncontrolled hypertension. We've seen the stress-induced cardiomyopathy, not too often, but we have seen that. Uncontrolled diabetes, severe anemia, and then pericardial disease. So the physical exam findings and a lot of these things, like we've touched on, like through some of the other slides, but what you guys might see, the patient may be tachycardic. Obviously, they may have peripheral edema, cool distal extremities, a narrow pulse pressure, which is really like a poor prognostic sign. Sharp peripheral pulses. Dr. Zamani, of course, I feel like is one of the best with physical exam and always checking a brachial pulse. Crackles would signify pulmonary edema. Decreased breath sounds, of course, is pleural effusions. Ascites, hepatomegaly. You may auscultate a gallop, and sometimes it's hard to differentiate between an S3 and an S4, but it's just, you know, if you know to gallop, like you just know that the heart is sort of like rocking in there and you know, maybe fluid overloaded or whatever. So sometimes I just say positive gallop as opposed to differentiating between the S3 and the S4. Of course, elevated neck veins with a positive hepatojugular reflex. The PMI may be displaced if you have LV hypertrophy. You may note a heave or a lift if they have RV failure. Of course, decreased urine output, and you might see increased frequency of ectopy or arrhythmias on the monitor. Any questions so far? And from the
question.
Yes.
Can you explain like the narrow pulse pressure and like why that's a poor indicator?
Yeah, I mean, really, the heart is just like really very poorly squeezing. So like sometimes people will ask like, what's the worst blood pressure to have? Like 80/50 or like 80/65, and it really it's that. It's just like it's just barely squeezing.
Okay.
And that's one thing, and I'll kind of get into like the when to call us, but I was just chatting with some of the colleagues, and that's one thing like we would really want to know is if you know, you're trending blood pressures, like obviously all of our patients have low blood pressures, but you know, is it new from their baseline or is the pulse pressure really narrowing? Then that's really a concern that, you know, they might be more low output than we suspect. Does that answer the question?
Yeah, no, thank you.
Anything else? Or from anybody on the call?
I have a follow-up question to that, because I was wondering the same thing with not just the narrow pulse pressure, but why does that cause a sharp peripheral pulses? And by sharp, what do you mean?
Yeah, so I mean, it's kind of hard to just like verbally say, but like if you're feeling a brachial pulse, and I don't know if you can like see or not, but like typically like it kind of goes up a nice smooth up and a nice smooth down. But if it's a sharp, it's like really like a kind of a quick point. Like you can, I mean, it's gonna take time to just like be feeling lots of pulses to really be able to tell the difference. But it might not be as bounding, and of course it's just this not like smooth sort of up and down feeling that you get. It's more of just like the quick pulsation, and it's just again really just that there's not much I guess ventricular contraction, if that makes sense. But I think too, like as providers, like, you know, if I ever find like an interesting physical exam finding, I do try to point it out, because I mean, they do it for us, the attendings, like we should do it for you guys too, so like we can just all learn. So I think like without actually feeling it, you know, it's kind of hard to explain, but hopefully, you know, if you just get into the habit of checking brachial pulses on your patients at least like maybe once a day, or if they have a change in clinical condition, you might be able to kind of appreciate that difference.
Is there any difference, like, on the waveform if you had an A line that could, like, correlate with that sharpness and touch?
So I don't know specifically, because like we don't have the A lines on the floor, so I haven't actually seen it like simultaneously. I would just like kind of guess that the waveform wouldn't be as pronounced, but I honestly I don't know the answer to that, just because we don't see the A line waveforms here as frequently.
Thank you.
Yep. So some of the laboratory findings that we might see, and the other diagnostic tests. So of course, like we see AKIs a lot, and with renal function and heart failure, it's could be a couple things. Like we usually say it could be congestion, like too much fluid, it could be too little fluid, or not enough blood flow to the kidneys. So you kind of have to take that into consideration with the rest of your physical exam if you think they're like congested or not. Bilirubin transaminases, it's the same thing really. It's typically congestion related or perfusion related. And the goal, of course, is with treatment like diuresis or increased perfusion, you would see those markers improving. Lactic acid levels would be elevated. We don't typically trend them, but it is something like if you're not quite sure what's going on, it would be worthwhile to just check a lactate. Bicarb levels kind of go along with acidosis. So it would if you had a low serum bicarb, you would probably also have an elevated lactate, or it could be related to renal failure as well. Obviously, the NT-proBNPs, we don't check them that often here. Like oftentimes they're checked on admission, or maybe for trends over time. They're most specifically used with the RV failure patients here in the pulmonary hypertension population. Hyponatremia, so if you have low sodium, and I mean, I feel like we see a lot of low sodiums here. So in the low 130s, like I don't get too excited about that, but if they're like persistently in the upper 120s, I mean, that really is a poor prognostic sign for long-term heart failure. And then acidosis kind of as mentioned. And then these are some of the tests, of course, that we order. Chest x-rays, of course, for like, you could see cardiomegaly, pleural effusions, pulmonary edema. You could see obviously lots of things. EKGs for new arrhythmias, PVC burden, like poor R wave progression, LV hypertrophy, all of the above. Echoes, of course, for biventricular function, any valvular abnormalities. Cardiac MRIs we like for any new diagnosis of a non-ischemic cardiomyopathy. That is really the gold standard for measuring LV ejection fraction. So sometimes you might have an echo that says like 60% and an MRI that says like 52%. I don't know, just an example, but the MRI would be the most accurate LVEF. And they do also quantify an RV EF on the cardiac MRI, whereas echo typically is just, mild, moderate, or severely reduced function. And then, of course, left or right heart catheterization. So management, I know you guys are all familiar with like the medications that we use. And as mentioned, like the most concerning hemodynamic profile for patients with heart failure are the ones that are wet and cold. So as Dr. Margulies once said to me, is that you need to warm them up before you dry them out. Like you have to have perfusion to the kidneys for any of the medicines to even work. You can try oral or IV vasodilators. IV typically is done in the ICU. We don't do those on the floor here like Nipride. And then the inotropes that we're familiar with, the milrinones and the dobutamines. Diuretics, we're all familiar with them as well. We could do bolus doses, drips, and if they're poorly responsive to either one of those, you can do the thiazide boosters, Diaril, metolazone. Some of that can be attending specific as far as what we choose, but they kind of both work the same way. When they come in and they're decompensated, we do typically hold beta blockers or reduce doses depending, if the clinical scenario, but just to note that beta blockers are negative inotropes. Same with calcium channel blockers like the diltiazem. So we typically avoid those with patients with heart failure. And then to kind of get that, the neurohormonal blockade, to kind of break that cycle that we sort of mentioned early on, we like our ACE, ARBs, and ARNIs, and actually the consensus update for the ACC guidelines for managing heart failure actually really pushes for ARNIs first if can be tolerated both by blood pressure and they're not cost prohibitive. So there really is a mortality and clinical benefit of using ARNIs if able. And if, renal function prohibits or other reasons, we can always use hydralazine and isotyl combination for vasodilator effect. And there is some proven benefit of even adding hydral and isotyl for African American patients, even if they're already on the ACE, ARB, or ARNI. Spironolactone and eplerenone. And then the SGLT2s, which obviously have come down the pipeline recently, both for HFrEF and HFpEF. Often not started on the inpatient side, but it is something that we do try to get patients on if they can tolerate them as an outpatient. And just a note about the management of our patients, they tend to have low blood pressures at baseline, and that's due to their underlying heart failure and also the medications that they need to be on. We don't usually hold the medicines if the blood pressure is stably low or they don't have any symptoms like, dizziness. So when you guys call and say, their blood pressure is like 86, do you want me to give whatever? We're happy to answer the question, of course, but let us know too, are they having any symptoms or any other, signs that they're not tolerating their medications? And if no, oftentimes we would continue to give the meds because really with consistent use and reduced hormonal activation, we hope for ventricular remodeling. And then kind of lastly, just like things that we would really want to know about, because you guys are in there obviously way more frequently than our 2 to 3 times a day, but any signs of altered perfusion, and that includes lethargy, decreased urine output, cool distal extremities, and then the changes in the pulse volumes and the pulse pressures as we mentioned. One thing I always tell people that I'm training or students is sometimes we're running in behind the attending. I hadn't had a chance to physically examine the patient yet. But at the very least, I always touch their legs just to really get an idea, do I need to be concerned about this person, and have a baseline too. We want to know any new rhythm problems, any increased ectopy. That could be a sign of if they're on inotropes. Is it too much inotrope? Is it too little inotrope? But, we want to know about that. Obviously, any new chest pain, shortness of breath, pink frothy sputum or signs of pulmonary edema, dizziness, lightheadedness, any new oxygen requirement, any blood pressure change from the patient's baseline. I know some people sort of wonder when to let us know about electrolytes, but I would say if they're having ectopy or arrhythmias, we want to know sooner rather than later, but just a general guide of maybe when to reach out. And we do trust your gut intuition. You guys have been at the bedside, longer than some of us providers. So if there's ever, you just don't feel right or, you want us to come take a look at the patient, we're happy to. And that's it. I know it was a lot for a 15 to 30-minute presentation, but again, heart failure really could fit in a whole day of a talk. So I hope that was a good sort of like review. And, you know, again, I love this idea to increase the collaboration between the APPs and the nurses. So if there's any other questions, I'm happy to answer. Yeah.
Is there any, where will it be stored if we want to use it for onboarding?
I'm sorry, I couldn't hear you.
I'm sorry. I see this is being recorded. Where will it be stored if we want to show it to other staff?
It's a good question. We
Yeah,
haven't figured that part out yet. But
It'll be stored in your Teams. I can,
okay.
because we do a lot of lectures and like meetings and stuff via Teams, so I can show you where it'll be
Yeah, I can
recorded.
at least share it with you, LJ, and then you can put it where on your SharePoint or whatever you want to do with it.
Okay, thank you.
Yep. I'm sorry, Jenny.
Are there any meds like offhand that you can think of that you didn't want us to give to a patient because you wanted certain things back before, or you want to see the patient?
So, I mean, and for those that are on the call, in case you didn't hear Jenny's question, but it was like, would there ever be a time when we might want to hold a medicine while we're waiting for a certain test? And I'm just trying to think like
Even if we're doing CAF numbers, or I don't know, Entresto, is there anything that like anything that happened recently for you to be like, oh, I wish the nurse didn't give that medication?
So the only things I can think of is like if I am following a patient for a few days and I see like a sudden change in their creatinine, I tend to reach out to the nurse and say like, please hold the ACE, ARB, ARNI, diuretic, or whatever potentially nephrotoxic medication until I come see them, because I want to assess like, do I think they're fluid up? Do I think they're fluid down? Like why do I think their kidney function is abnormal? So you know, and as the bedside nurse too, I mean, I know you guys see the labs. If you see a change in a lab value and you want to reach out, I mean, I think holding it for an hour while we can sort of sort out and make sure that it wouldn't be detrimental to give the patient, I think that that's important. You know, we want to kind of figure out what's going on, but I can't really think of a specific med that I could say like, if we're waiting for this, I want you to hold that. It's kind of on a day-to-day basis.
What are the core meds that we would expect every heart failure patient to be on when they come through the door?
Yeah, so the GDMT or guideline directed medical therapy, the goals are to get patients on beta blocker, some type of vasodilator or neurohormonal blockade, and that's the ACE, ARBs, ARNIs, hydralazine or Isordil, an MRA or mineralocorticoid receptor antagonist, and that's also like a hormone target. And then newly this SGLT2 inhibitor. So it's the 4 classes: beta blocker, vasodilator, MRA, and SGLT2s. Oftentimes in the acute, like decompensated state though, like we don't do beta blockers. That's typically if they're compensated and euvolemic, we'll start them or like get them back on their home doses. So we probably won't see them on them like while we're actively diuresing or whatever. And then the SGLT2s, we typically, when they're not on formulary yet, and just with like risk of being NPO and like the euglycemic DKA, we typically don't continue those as an inpatient. So the biggest things you would see would be the vasodilators and then MRAs. Some of our attendings are better about like trying to sneak on a little bit of each class of medicine while they're here. And then their outpatient team is more apt to like optimize them. If they're discharged on like 3 of the drug classes, sometimes those 3 get optimized before adding the 4th. And really the benefit comes from being on all 4 drug classes. And then of course, inotropes. I mean, I didn't touch on that. This is more like a kind of general thing, but you know, most of our patients are on inotropes too, so. Anything else? Thank you.
Thank you.
Good, thanks.
You're welcome. Thank you guys. I'm looking forward to this endeavor, so I appreciate everyone's participation.
Yeah, thank you.
Great talk, Lauren.
You did great. Did you listen to the whole thing?
Yeah.